Nau mai, haere mai, and a very warm welcome to you this evening. My name's Nicola Batossi. I'm General Manager at Multiple Sclerosis Auckland. Before we launch into tonight's session, I'd like to open tonight with a karakia. The translation is come forth from above, come forth from below, from within, and from outside the environment. Vitality and well-being for all, strengthened in unity. Right. Tu tawa mai I runga, tu tawa mai I raro, tu tawa mai I roto, tu tawa mai I waho. Kia tau ai te Māori tau, te Māori ora, ki te katoa. Haumea huia, tā kia. Right, well, thank you. Thank you so much for taking this time out of your evening. This is a topic that is really important for us to cover, and I'm just delighted that we're addressing it tonight. So we've just concluded our MS Impacts survey for 2026, which many of you would have participated in. And the data is that of our membership who responded this year, 77.2% are affected by continence issues to some extent, and 42.6 are extremely or quite a bit impacted. So it's a massive issue, but something that just doesn't get enough airtime. Hence the title of tonight's webinar, Let's Talk About Continence. So I'm really pleased that we can help bring this out into the webinar forum and start a discussion about it. So tonight we are joined by KJ Lazarus. She is an MS immunotherapy and continence specialist nurse at Austin Health in Melbourne. I've heard about KJ for many years now, so I'm delighted that we finally get her in front of our community. This is her area of specialty, and she's asked all over the place, all over the world, to talk on this topic. So thank you so very much, KJ. She's joined tonight by Brett Drummond, Director of MStranslalte, who will be known to many of you, and is really helping us a lot with all these webinars and resources. So we're very grateful to you as well, Brett. So tonight will be a discussion format, but if you do have any questions during the session at any point, then please just type them into the Q&A box, and they'll try and incorporate them into the chat as it goes. Thank you everybody for joining tonight, and to KJ and Brett, and I shall hand over to you now.
Thanks, Nicola, and let me echo Nicola's statements, KJ, and thank you for joining us on this webinar to talk, as she said, about a really important topic that we probably don't talk about enough. For people who are tuning in, as Nicola said, we will be monitoring the Q&A box throughout the discussion, so please do send your questions through as you think about them, and we will bring them up and discuss them during our chat, and then we'll also have a bit of time at the end for extra questions that come through. Understanding that this can be a topic that can be quite personal to a lot of people. I won't read out names associated with the questions necessarily, as this is being recorded, so you can keep your questions anonymous as well if you'd like. But we really want to make sure that this is a safe space to be able to talk about and ask questions on a topic we know is of importance to the MS community, and a great opportunity to ask someone who deals with these questions all of the time and has for quite a while now. As a starting point, I think Nicola, gave us a really nice starting point by talking about how common this symptom is, or these symptoms are in people living with MS in New Zealand. Is that sort of that figure that we were talking about there, 77%, pretty consistent with what you would see in Australia and around the world reported on this, KJ?
Yeah, actually, I was really interested to hear those statistics from this recent survey of your local population, and thank you for having me from across the ditch. So my experience is obviously Australian, but I can sort of say that that is very consistent. Sort of the worldwide data is that about 30% of the population experience continence, of the healthy population, of just the general world population, suffer some sort of continence dysfunction. But in the MS population, the data is somewhere between 70 and 80%. So you're sitting right in that sweet spot of what the data has been saying for some time now. And the data is a little bit of the newer side. The continence prevalence information has sort of before about 10 years ago was sitting in mumbled and jumbled up with other spinal cord injury patients and other sort of spinal, but in the last 10 years it's definitely been an area of focus specifically for people living with MS, because it is a well-known common symptom of MS, and not necessarily everyone with MS, living with MS, understands that to be so. So a lot of education around this is amazing and great to have this opportunity to freely talk about it. And as one very good MS nurse who works out of Auckland says, get rid of the loo taboo, and talk about it a lot more, because there's clearly a lot of people having some level of dysfunction. So very happy to be talking about it tonight.
And I think that's a really important first step in the conversation. And this is true of lots of different symptoms of MS, but it's obviously a disease that people experience very differently, at different times, even within an individual. And so often, there is a feeling of, is this just me? Is this, and that uncertainty and that isolation. So I think hopefully as a really clear message to start off this webinar, to people who are listening in, this very likely isn't just you. This is a very common symptom.
Absolutely. And I think sort of society has sort of shaped our thinkings around it as well, that, the really people don't talk about it. It's, it's a loo taboo, and people feel very vulnerable to talk about it. But the reality is, if we all eat and drink, we all have to get rid of that waste somehow. So we're going to all poo and wee. But a lot of the information we get is from commercials. And so, if you've had a baby and you have a little bit of an accident here and there, it must be because of that. And no one's really sort of addressing the other reasons why people have continence dysfunction. But I think that's slowly starting to change, and it's good to see.
Okay. Well, I think we're definitely going to get into that across the course of the webinar. What question I guess I have to start with around this, for people who live with MS who do experience continence issues, is it something that once you experience that symptom, it's then something you will continue to deal with throughout your life? Is this something, similar to how people experience relapses, that, it comes and then you'll have these periods of remission? What is, how is that actually experienced by a person living with MS?
Like you said before, with MS, everyone's experience is a little bit different, and everyone's journey, and I don't love that word, but it's a good fit, is always going to be a little bit different from person to person. And so there is potential that if you have some dysfunction, that it may be something that worsens at certain periods and improves at other times. It could be a new permanent thing. It is a symptom that could actually be the first symptom of MS that people have experienced. So people have been diagnosed with MS, starting their journey of diagnosis through having bladder dysfunction or bowel dysfunction and seeing a urologist and sort of coming the other way. But it also can be something that develops later in a disease process. And so it's very individualized for people. It is part, I think most people listening, I'm assuming, will have had an EDSS assessment with a neurologist or a specialist at some point. And part of that assessment is actually a question about bladder and bowel. And so I think historically, before sort of 10 years ago, maybe didn't ask the questions around that well enough. And I think that's definitely changed. But again, it is something that we should be talking about, because we do know obviously that it is a symptom of MS, and along with other things, but and also it can be very common. But as much as it differs between people, the the symptoms themselves, while there are again some common symptoms, the variability of it is very wide. And so there are some changes that may occur that you can manage very well with either lifestyle or behavioral things. There's the other end of the spectrum where you might need intervention. But you also have to remember that you may have bladder or bowel dysfunction that is maybe not part of MS and not part of your diagnosis, because you can get bladder and bowel dysfunction for other reasons. And so this too is another reason it's really important to talk to your healthcare teams about, if you are bothered by bladder and bowel symptoms, that you talk up about them, you explain what they are, and then, follow up on them to work out, what's happening and what can be done about it.
Yeah. And I think there's a lot there that we want to go. So Ray, sorry. No, have I just absolutely deafened you with that?
No, not at all.
Okay, good. Hopefully my audio is better now, Ray. Sorry, I realized it wasn't actually picking up my proper microphone. So hopefully you can hear me a bit better now. People were saying they couldn't hear me and could only hear you, which to me sounds like a much better outcome for our audience if they can only hear you and not me. It's the first time anyone's asked me to turn my volume up and not the other way. So hopefully that's better, Ray. I guess one of the things, as we go, now apparently it's worse. Can you hear me fine, KJ?
I can hear you really well.
Okay. Ray, it could be something going through. I'm going to just try and keep going on. If other people who are tuned in are having any issues with my audio, can you let me know and I'll see if I can sort it out. So I guess one of the things as we go through this, we have a lot of distinctions around different things that we need to talk about. So in terms of continence, we have bladder and bowel, and we need to talk about those separately. We obviously have, apparently people are really struggling with my mic audio. It's not just them. Sorry. I'm going to finish this question, KJ, and you can talk it through and maybe put it into the context.
Yep.
We also have men and women. And then we also have relapsing remitting and progressive MS. So what do we know about differences between those? I'm just going to get really close to the mic and see if that helps people.
Really good question. It's interesting, the type of MS, it doesn't really seem to affect things differently. Like if you have second progressive or funnily enough, primary progressive is a little less prevalence in my experience, and that's anecdotal. I don't have statistics around that. However, relapsing remitting versus second progressive, it just occurs sort of equally amongst people. It was a bit what I was saying before, that it occurs in people at different times, and there doesn't seem to be any sort of precursor to that. And what level of dysfunction it is in different people is very personal to the individual. In relation to sort of female to male, obviously with MS, we have 3-to-1 female to male with the diagnosis of MS. But equally, it's about equal that you have a level of potential of level of continence dysfunction between males and females. So obviously we see more females because we see more females with MS, but sort of the likelihood of having some bladder or bowel dysfunction, it doesn't seem to be impacted if it's neurogenic. So neurogenic is the word that we use when you have bladder or bowel dysfunction because of neurology, so because of the MS itself. And the symptoms, we might talk about this later, but the symptoms are a little bit different when it's neurogenic based or from a neurology reason that you're having the dysfunction. And so, again, there may be other reasons, and you might get what we call a mixed picture. So, for example, if you are a woman who have had children or multiple children or traumatic births or large babies, you may have a mixed picture where you may have signs of stress incontinence. So, you don't want to go to bounce to jump on a trampoline and laughing at certain movies and things like that. That is more the stress incontinence. And that's actually not very common. That's not a symptom that's associated with a diagnosis of MS. And so you might get a mixed picture where sometimes it's, you might get some symptoms from MS and some symptoms from other causes, or you might just have symptoms from other causes. And again, like I said before, it's really important to talk about them, the symptoms that you're experiencing with your healthcare professionals, so they can help you work out, what the cause of the dysfunction is and the best way to manage it. And also men have prostates. And so maybe in the older population, it's something that we do have to consider to differentiate between, what the cause of the dysfunction is. But it doesn't matter what the dysfunction is. I think it's really important to understand what's causing it. And so we often ask questions and around that to try and help work out what's the cause of the problem. And then that helps us to shape the best way to manage the problems.
So I think that's really interesting, and I think that's then a really good spot to talk about next is, I've already said that the conversations around this are difficult. There's conversations that perhaps don't happen as much as they should, and it's something that people feel like they don't necessarily want to talk about. For you, having probably engaged in a lot of these conversations, what would you recommend to someone who is someone living with MS who feels like they might be experiencing symptoms around this? How do they start a conversation? Who should they start that conversation with? What are the sorts of things they should be sharing as part of that? And how would you navigate it from your perspective as an MS nurse?
Yeah, so that's a really interesting question. I work in quite a large clinic in Melbourne, and I don't actually take external referrals or see people purely for continence as a referral service. So I work primarily as an MS nurse, and then I have developed this special interest and this specialty area of care in MS. And so people that come to our service that they've picked up that there's some bladder or bowel dysfunction and sexual health dysfunction as well, then the neurologists or one of the team, nursing team as well, might say, well, I think you need to go and have a chat to KJ. And so they come to talk to me about that. On the flip side of that, sometimes I've just spoken to patients and they're saying things like, for an example, this is just one example, that as we know, fatigue can be a big issue with MS. And so when we sort of say, oh, what's happening with the fatigue? How's your sleep? What are you doing for work? How's your exercise? And they might share that they're not sleeping very well. And so go, okay, so what's wrong with the sleep? What's happening? Are you having trouble getting to sleep, staying asleep? And then some people have sort of shared that they have to get up and go to the toilet 4 or 5 times overnight, and that's why they're not sleeping. And then that creates the conversation of like, that's not normal, like not normal, but that's going to be impacting your sleep. And I think that could be something that we need to understand a bit more why that's happening to make that better and stop that from happening so you can sleep more. So sometimes the conversations happen very direct. Some patients have sort of over time, and especially in our service, I think, because we do talk about it a bit more. And I think now having a little bit of a pathway where we have better understanding as MS healthcare professionals, I think the neurologists are asking better questions. I think the MS nursing staff are asking better questions. And I think we've found from that perspective, when you ask the right questions, people are actually quite relieved and happy to give you the answers and have an opportunity to talk about those concerns that they're having or the areas of bother that they're having. On the flip side of that, some people are very comfortable talking about it, which I always applaud, and I'm very happy about it. But also we need to educate our patients, and this is a great opportunity what MS Auckland are doing tonight, to explain to people that this is very common. And that your healthcare professionals are there to help you to talk about these. If you are having, bladder and bowel is an area of concern and bother for you. There's also some tools that are available. So I know on MS Auckland's website, there is the Coloplast MS bladder check tool. So that is just a 1-page, very simple questionnaire that you can complete yourself. And if you answer yes to, it's just a very simple tick box, but if you answer yes to any of those questions, that is a tool that you can then take with you to a healthcare professional appointment. So whether that's an MS nurse or a neurologist or, even if it's a GP, it is a good starting point to have that conversation, because it sort of breaks down a lot of the symptoms that are very common with MS. as far as neurogenic bladder dysfunction and bowel dysfunction are on that questionnaire. And so sort of the arrows are pointing to some dysfunction because of MS. So if you would like to do something like that privately, you know, in the privacy of your own home, to sort of see that first and then take that as a trigger to have a conversation, I think that's also another option. But I know for a fact that there are some very good MS nurses throughout New Zealand and the South and North Island that have a very good understanding and becoming quite good continence nurse specialists in the MS space themselves. And they have created and put some information on MS Auckland's website with Fiona DeYoung from Auckland herself. And so there are people definitely with the knowledge to support this area of MS care.
And I think, and we will come back to this because this is obviously a really important part of what we're going to talk about tonight. But I think the big thing that's already come out of this is that if you talk about it, there are things that can be done. This isn't a thing where you talk about it and it's like, okay, well, it's good to know you experience it. There are strategies where this can be improved. And as you said, it can have, the other thing I want to delve a little bit more into is impacts that it has beyond, you know, the continence. So you've already brought up sleep, which I think is a really important one to discuss. But just for, I guess we sort of use these terms and we probably have a bit of an idea of, you know, continence and what it might mean. But for a person living with MS, what are the sorts of things that they may notice? How might it actually present as a symptom that, you know, you would classify as, okay, there's a continence issue here that we need to think about?
Yeah. So the common neurogenic bladder signs, I'll start with the bladder. There's a silly acronym, which is funny, but it's not very funny. And that's just one way someone told me that when I was starting off in this sort of area of specialty, that's really stuck with me. But it's an acronym for frequency. So when you feel the need to go to the bathroom to have a pee frequently, so every 2 hours or hourly or more so. You have urgency when you're perfectly fine, and then all of a sudden out of nowhere you need to go and have a pee like 5 seconds ago, and you need to find the closest toilet as soon as possible. The N is for nocturia, so that what that means is having to get up overnight to have a pee. Now, it is normal to get up once or twice a night. When it gets sort of 2 to 3 plus times a night, that is more sort of a medical nocturia, that there's usually some management strategy that we could, you know, look at and think about. And it's I for funny, but I for incontinence. So it can come with sudden leak. So leak with the urgency when you're like, oh, I've really got to go right now, and you have a leak. That is also a possibility. The other symptoms really commonly with neurogenic bladder is when you're busting and you sit on the loo to have a pee and not much happens. So you know that there's something in there, but you can't get the flow going. Or the flow starts, but then it stops and it starts again, and you sort of have what we call an intermittent flow, which literally just means it stops and starts, like on and off. And sometimes you're sitting there and you think, I know there's more in there and I just can't get it out, but I could sit on the toilet for half an hour or 45 minutes and it's still not going to come out. Or you do the wee dance on the toilet, or you push on your belly and rock backwards and forwards to try and squeeze that urine out. They're all signs that are commonly linked to neurogenic bladder dysfunction. They represent a few different structural changes and functions of the bladder, but they're the common things that people often report when MS is the culprit of their bladder dysfunction. With the bowel, most commonly, and it's sometimes a complete reverse, but most commonly, constipation. So constipation occurs in MS because the nerve stimulus to the large intestine, so that's the part of the intestine just before it gets into your rectum into the outside world, the nerve stimulus to that part that moves the bulk through the intestine is affected, and it becomes very slow. And so the role of the large intestine is to pull water out of the stuff inside, and there's no on-off switch. So as long as something's sitting there, it continues to pull water. So the longer it sits there, the drier it gets, the more backed up it gets, the more constipated you get. And so the constipation is the most common because of a slow transit time through that part of the intestine. So that is very common. Occasionally you get the complete opposite and it goes through too quickly and it just comes out as water all the time. But I have seen it, but it's quite rare. Some people come and talk to me and say, oh, I just don't know what's going on with my bowels. 1 minute I'm constipated, the next minute I've got diarrhea, and it's just yo-yoing backwards and forwards. When asking more questions about that, more often than not, that is a sign of actually severe constipation, because the body is pretty clever and realizes when there's I call it a brick for a term, which is, not so nice, but reality, it feels like it. The body recognizes as a blockage and creates a bit of a lubricant within the intestine and the rectum to try and help move that along, the blockage along. And so that comes out as sort of like a mucousy, liquidy, kind of mustardy colored, and diarrhea is what people describe it as, but it's actually not diarrhea, but it's the body's way of trying to combat the constipation it's picking up in itself.
Okay. And so I guess that's going to present differently in different people. We've already sort of talked about that. At what point would you recommend that a person comes and talks to someone? Is it as soon as they think, hey, this isn't my normal, this is something that's starting to impact me? What time should they start to have a conversation around it?
That's a very, very good question, because I'll just say as soon as you notice something that doesn't seem right. And that's true of many things. So if it's impacting on your activities of daily living or your way you get through your day, how you manage at work, all of those kind of things, obviously it's impacting it. It's going to be a level of bother to you. So if it's bothering you, you should absolutely talk to someone about it. We do often ask, or I often ask as part of when I do a continence assessment, is in particularly with the bowels, but is this a lifelong habit? Is this something that's, are you prone to constipation? Has this been something that's been happening forever for you, or is this something that's new or is evolved around the time of diagnosis? Or I often shape that question depending on who I'm talking to and what I know at that point when I get to that question. But I think like I mentioned before, as part of the EDSS, and I sometimes call it the chicken dance, asking the neurologist will be asking you, how's your bladder and bowel? Now, that may be the question they ask you literally, how's your bladder and bowel? Now, that is not an opportunity for you to go, well, it's actually really bothering me, but I'm making do and I'm managing okay. So what I'm going to say is it's okay. But in reality, you're getting up lots of times at night. You're choosing to your job allows you to work from home, and so therefore you can go to the toilet every hour if you need to. But if you needed to go out and about, or maybe you're choosing not to go out socially anymore because you don't know where the bathrooms are, and if it's impacting you in those ways, you should absolutely say, actually, it's bothering me and it's getting in the way of life a bit, and this is what's happening and I don't know why. And you don't have to know why. That's why you have the healthcare professionals on your teams to help you, navigate that. So I would always say, if you've got something that's bothering you, you should always bring it up. But also, when the docs and the nurses and the MS healthcare professionals ask you that question, how's your bladder and bowel, be honest. And if you've got a symptom that's bothering you, even if it's a little bit, there may be some really simple lifestyle things that you can do to change it. So instead of drinking 7 cups of coffee a day, it might be as simple as having 2 cups of coffee a day. So it might not be, as a terrible conversation or a very confronting conversation. It might be some very simple things you can do to make things a little bit better.
Let's delve into strategies, because I think that's really important and I want to make sure we have time to do it. But before we get into that, I just want to share a comment that's come through in the Q&A to sort of highlight how important this conversation is. The comment that's come through, I had no idea those bladder symptoms were MS related. I assumed this was something everyone experienced. Thank you for this information. So already we can see that this is, really important things that you're sharing with us at the moment, KJ. Strategies. I think we've talked about raise it, but we know a lot of times, and this is true of various symptoms, people will have that response of, yeah, it's fine, I'm coping, because people living with MS find a way of adjusting to their new normal and just getting on with it. but often also because there's this idea, and whether this is coming from healthcare professionals or coming from other conversations, that, you know, this is just part of living with MS and there's not a lot we can do about it. I think it's really important in terms of this that we discuss there are things that can be done about it. So I'm going to leave that as a very open-ended question to you, because I'm sure there's lots of different things that you could talk about here, but what sort of strategies can be implemented for people who might be experiencing continence issues?
So I'm going to go with the first one, is self-advocacy. Mm-hmm. So I know that's probably not what you'd think I would say in this moment, but I think self-advocacy on this topic is really important. And I think because whilst, you know, a lot of people know what MS is, but for example, there's a lot of GPs who, you know, GPs know a little bit about a lot of things, but maybe not deeply know about many things. That makes sense. I mean, a lot of GPs often have a subspecialty, and that's often due to interest or patients that they've had an experience with. But I think, especially with continence, because I think this is something that has been said, it's been fed back to me, that's been said to many people living with MS, and especially when I first started getting into the continence space where I work, was that they had brought these concerns up in the past with, say, for example, a GP, and the GP said, oh, it's part of it. Oh, we know that this is part of MS. You have, you know, this can be a symptom of MS. You just have to live with it, or you just have to adapt to it. So this is where I think self-advocacy is really important, because that actually is not true. There are lots of different levels of management strategies that are very effective that can really change the impact of these symptoms on people living with MS in relation to bladder and bowel. In the first conversation, depending on the person and their symptoms, there is as wide a range of symptoms and severity of the symptoms in individuals. There is a very wide range of treatment options. So again, this is why it's important. If you've got something that's bothering you, that's new or hasn't been around that long, do talk to your healthcare professionals, because the longer you leave it, sometimes it can be, you know, more significant management strategies need to be implemented. So sometimes simple things can start in the beginning and you get good habits. So sometimes some of the lifestyle things, obviously caffeine can be really high level, you know, high amounts of caffeine can be really irritant to a bladder. For some people, just fizzy drinks, so even just soda water, carbonated water, because the bubbles themselves break down into sort of, once it gets mixed with water, when you drink it, it turns into an acid, and that acid for some people can be enough to irritate the bladder. So some people, if you're drinking a lot of fizzy drinks and having a lot of frequency, and a little bit of urgency, maybe see if you can change some of those things, a little less caffeine. I often say to patients, you're not dead. I'm not trying to get you to quit coffee, and you know, a lot of people need a good coffee, and sometimes coffees can actually be really good. There's a thing called a gastrocolic reflex. So when you get up in the morning and you have a coffee, it actually wakens up your bowel a little bit, and you get a bit of extra movement, and your bowel moves a little bit more. And so some people use that to actually empty their bowel. So I'm not saying don't drink coffee, but if you're drinking 8 coffees a day, you might, and you're having lots of frequency and urgency with your bladder, you may need to consider how much caffeine that you're consuming. There's also sort of what fluids you drink at what times of the day. Another thing we haven't really talked about, which is really important in MS, is urinary tract infections. So one of the symptoms I talked about before, sometimes the bladder doesn't empty very well as a symptom of neurogenic bladder dysfunction. And so a little bit of urine gets left behind. And so bacteria loves to grow in a stagnant puddle. So having this little bit of urine left behind in a human body that's at a perfect 37 degrees, bacteria does love to grow in that kind of environment. And I'm not sure if anyone listening today has had a UTI, a urinary tract infection in the past, but it can exacerbate their normal MS symptoms and cause a pseudo flare. So it doesn't give them new MS activity or new MS lesions. It just makes the MS symptoms they've had in the past accentuate and worse and impact them, and can be a very high reasoning for hospitalization. Especially for people with more the secondary progressive or higher levels of disability. And so it can really be very impactful. The other thing is often with the UTI, so I've gone off course here, sorry, is that the signs and symptoms of a UTI can often be not very different, but a little bit different to someone without MS. So with MS, as many people might understand, is that you can have some sensory changes. So you can get some numbness or some areas that you just don't feel the same as you used to. And so having a burning sensation with a urinary tract infection, which is one of the common symptoms they talk about in the general population. It's very common not to have pain with a UTI and MS because of the sensory changes. So you might have increased frequency and you might have increased urgency, but if you're already having frequency and urgency, sometimes it's hard to differentiate between if this is normal or more than usual, and if you don't have burning but there's a whole lot of things that go around that. So keeping your fluids up, it seems sometimes counterproductive when you have frequency and you want to go all the time. So like you very eloquently said before, people with MS are very good at adapting and very good at adjusting to live life and aiming to live well with the symptoms that they're dealt. And so it is not uncommon for people that have urinary frequency and urgency to drink less because they think that they're drinking too much. So if they drink less, they'll have less frequency and urgency. But unfortunately, with neurogenic overactivity, when you get that frequency and urgency, it doesn't really matter how much you drink, unless you're drinking 3, 4, 5 liters a day. Then yes, that is a volume intake issue. But you need to actually be well hydrated for the bowels to work well, but also for kidney health. So, the urinary tract has the upper urinary tract, which is the kidneys, and then the 2 tubes that lead into the bladder, and then the lower urinary tract, which is what often causes a lot of issues with continence in MS, is the bladder itself, the valves to the outside world, and the pelvic floor. So diet matters, fluid matters, reporting, being a good self-advocate if something's bothering you, talking about it. There are some medications that you can try, but as the symptoms go on, and if you try lifestyle things, then we can go on to what the next step is and what the next step is. And it can be a bit like a pyramid. There's a few more options at the bottom. If that doesn't work, then we step up. If that doesn't work, we can step up, but with an understanding of actually what your problem is and what's driving your dysfunction. And then we work with individuals to try and find the right fit.
Okay. And does that...
Sorry, that was a lot.
No. And it's a lot because there's a lot to talk about. And I think there's really, the stuff that you were just discussing around the UTIs is really important. And again, even from my perspective, that's stuff that I'm learning as part of this as well. So the information you're sharing is fantastic. You've talked a bit about how there can be continence related to MS and then continence that's not related to MS. I don't know how easy this as a question is to answer, but how do you go about distinguishing between those, if that's possible? And if it is, are there different strategies that you might implement if it's not MS-related continence?
Yeah, so I think the important part is the assessment. So to be honest, when I do a full continence assessment with somebody, it takes about an hour or so. It takes a long time because I need to understand where you're at now, what's bothering you, how it's working, but also your complete medical history. If you're a male, what age you are, if you've had a prostate check, if you're female, have you had children, how many and how were they delivered? Have you ever had trauma? Have you had a hysterectomy? Have you got irritable bowel syndrome? There's a whole lot of other things. Also of consideration is with MS, as we touched on before, you can have lots of different symptoms with MS that might need different management strategies. And so some of them might be medications for spasticity and medications for a mood or anxiety and medications for other things, pain. And so some of those medications can make constipation worse, can make bladder frequency worse, can make bladder frequency better. So you need to understand all of the patient as a whole, and I try to do it as holistically as possible to understand, to be able to differentiate between, ruling. Sometimes you have to rule things out as opposed to ruling things in. So you sort of have to go through a bit of a list of and listening to the patient about what their symptom is. I think I touched on it earlier around stress. Urinary incontinence is just sort of an example where if you're somebody who has accidental leakage when you are coughing, sneezing, laughing, jumping on a trampoline, but you don't really have the frequency and you don't really have urgency or stop-start flow, and you've got a history of having multiple children or a 10-pound baby, for example, then maybe that would make me think about your pelvic floor being insufficient. It might be more of a stress urinary incontinence. And so pelvic floor physio and, they might want to then refer you on to someone else, like a urologist who specializes in stress urinary incontinence. Continence urologist, this is sort of tricky too, and pathways, and I think MS nurses around Australia and New Zealand struggle with this, because I know that we have talked about this, is clear pathways for people to go in the specialist space to find the right fit for their concerns and their problems. So urologists who look after bladder in MS in Australia, they tend to be what we call functional urologists, and sometimes they're actually geriatricians, because geriatricians can be very good with functional continence. And if we're I'm very lucky at the Austin. I have access to both functional urologists and geriatricians who have a very good understanding of functional continence of all ages. So even though geriatricians are doctors who generally sort of by title look after geriatric patients, so the older population, but are very good at functional continence of all ages, and so that's more the overactive bladder and those kind of things. And so sometimes it's trying to find the right fit. So if you are speaking to an MS nurse or your neurologist, your MS doctor, then hopefully they know the right people in your areas, in your cities that you might need to go to for a specialist opinion. The other thing is there are some tests that can be done. There's one called a urodynamic study. Don't Google it. It'll terrify you, but it's really not that bad. But there are specific studies that can be done that enables us to physically see what is happening, especially for patients that have the stop-start flow, so the intermittent flow or hesitancy, incomplete emptying, those kind of things. So we can see if there's an obstruction. So if there's something that's not MS related, there's something blocking the flow, or whether it is a neurological process causing some sort of obstruction, or the valves. So the bladder, male or female, you have a bladder that looks a bit like a balloon with a fuffer valve down the bottom, and it has two valves, and then the outside weld. So sometimes the bladder muscle itself and the two valves aren't coordinated because of a disruption in the neurology. And so that becomes uncoordinated. So the bladder might be trying to squeeze the urine out, but the valves won't open. So there's a few different things we can do, and that's part of a good assessment and having access to, say, being able to do this specific urodynamics study. And so therefore they can then create the best management plan to fix the symptoms that they've found.
Yeah. I mean, I don't want to keep harping on it.
Sorry.
I feel like I've said it. No. I'm going to say something that I seem to keep coming back to, but it's, I'm probably biased considering what I do, but communication is key around this topic. I mean, just some of the things you're talking about there in terms of, non-MS related continence issues. So let's not have people, if there is a continence issue, just assume it's an MS thing. And so there's nothing that can be done about it. But then having, then being able to go to, all right, I'll get a physio into my management team and then pelvic floor muscle training. None of that happens unless the conversation starts and, the assessment's done. So I think, again, this is really important. Also highlighting again how important it is, just going to read a couple of comments. Well, one comment and then a question that's come through. And I think the comment is really important to show the impact that this can have on people, that the symptom can have. So something that affects me as much as urinary retention issues themselves is UTIs. I get them very frequently, despite doing everything I can to prevent them. The fear of continuous infection stops me from doing a lot of the things that I'd like to do, which is disheartening.
Yeah, it is disheartening. And so thank you for sharing that story, because that is actually not an uncommon story. That happens quite a lot. And I think it really highlights the need for good understanding, for understanding the process of what's happening and being able to share what is going on, because obviously you're limiting your social activities, the self-worth, it's painful, it causes other problems with your MS and things like that. So to talk about it and find appropriate management strategies, and if you're in retention all the time, there are management strategies for that. And whilst the initial conversation of that might be terrifying, I'm going to go there, but the gold standard for retention when people are getting recurrent UTIs might be something like intermittent self-catheterization. It's not a skill anyone's born with, but it's definitely a skill that most people can learn. And at that point, then you know that you are emptying your bladder at certain times during the day. So there's none of that sort of leftover stagnant puddle, for want of a term, left over. On top of that, if you're already somebody who's had lots of urinary tract infections, sometimes you might be on an antibiotic that you actually have a resistance to. So hopefully if you're having signs and symptoms of UTIs, you are always sending off a sample, having it cultured, making sure whatever management strategy you are doing. And then if you continue to have infections, you do need to talk to your team about that. And because there may be some other specialists that you might be able to go and see about problematic infections that seemingly aren't going away. So I'm going to stop there. I could go talk more about that. I think that might be a conversation for another topic.
Yeah. Well, we are coming towards the end of the webinar already. So if you do have questions that you would like to ask, now is the time to put them in the Q&A. Really appreciate all of the comments and questions that have already come through and people's willingness to share and talk about this topic. It is really important. So we do have another question that's come through, and it's around strategies. And so the question is, at what point would Botox for the bladder be considered?
Yeah. So Botox is a great medication that they use injected into the inside of the bladder muscle itself for neurogenic overactivity. So that's when you have the symptoms of frequency, urgency, and it can be, some people have to get the urge to pee every 20 minutes. So when patients come to me, and this might be a KJ thing, so they come to me and they say, oh, I need some bladder Botox. I want to have bladder Botox because I'm going to the toilet all the time. And maybe they've not talked to me before about their bladder dysfunction. And so I said, I think we need to talk about the whole picture first and then talk about it, because if you want to do bladder Botox, you have to learn how to do intermittent self-catheterization. Now, the reason for that is that Botox is a paralyzing agent. And so in the non-neurogenic population, so it is possible to have overactive bladder syndrome. So that does give people the similar symptoms of frequency, urgency. However, it's not nearly as frequent. It's not nearly as intense in urgency. And when they do specific pressure studies within the bladder, the pressure that the bladder contracts at is much, much higher in people with neurogenic overactivity, and also increases the risk of having flows from urine flow from the bladder itself up backwards, backflow back up into the kidneys, which can cause lots of problems and much harder to fix. So I forgot what I was going to say about that though. Anyway, so just remind me the question.
Around Botox, when are we considering
using Botox?
Botox?
Yeah, sorry. So what the Botox does, it relaxes it. So with the patients that don't have MS, the Botox, the amount of Botox that population needs is about 100 units, right? And it lasts about 6 to 12 months. Normally in that population, 9 to 12 months. Mm-hmm. In the neurogenic population, usually, I actually can't think of anyone at the moment that I know of in my service having Botox. 100 units isn't enough. It doesn't cut the mustard and doesn't work. And so most of the patients that I know that are getting Botox get 300 units each time, and it only lasts about 6 months because the symptoms are more significant, but also it needs more punch from the Botox. And so sometimes the intent is to paralyze the bladder and make the patient or the person reliant on intermittent self-catheterization. And sometimes it's not quite to paralyze it, but the risk of retention is much, much higher in the MS population when you use Botox. So I advise patients that if you want to do bladder Botox, you also have to learn intermittent self-catheterization. And for some people early on in the conversation, that turns them off pretty quickly. However, it does enable us then to have a conversation and look at other strategies that we can try and implement and try first. And if that fails, then maybe Botox is a good option for that person, because Botox is very good for the right patient. So I've had patients that have had Botox for nearly 10 years now, and they have it every 6 to 9 months. They kind of manage that themselves. They know in the beginning when they first started having it, the Botox as is designed by design, it does wear off after a while. And so the patients have learnt how to manage that themselves with, say, an oral agent such as Ditropan or something like that in the short term while they're waiting for their next top up with their Botox. Occasionally it doesn't work for reasons we don't know, but that doesn't mean if you had Botox a few times and then you have Botox again and it hasn't worked like it usually does, it doesn't mean that it won't work again. It's just sometimes for some reason it just doesn't have as much effect. I don't know why that is. I don't know. I'm not a urologist. I don't know. But yes, it can be really effective for the right patient with the right assessment and trialing others, the pyramid again, trying out some of those strategies.
So we've got a question on a similar thing, and I think this is going to be, I guess we need to answer this in a very general sense because we can't answer it on an individual level without doing all of the assessment of this person. But person said they've got an overactive bladder. Their urologist who specializes in neuro has put them on catheters because they can't fully empty and get frequent UTIs. Would Botox be an option in that sort of scenario?
Yeah, I think, look, it is a question absolutely for the specialist. And what I can say is that there are patients that I know of that have both. So they do regular intermittent self-catheterization because they need to know that their bladder is emptied a few times a day. Usually, on average, it's 4 or 5 times a day, but sometimes people just do it 3 times a day. But they still, despite doing intermittent self-catheterization, and it might be because their bladder gets overactive with relatively small volumes in it, that they need the addition of something else. So the addition either of an oral agent, and it might be Ditropan or Vesicare, I'm not sure what that's called in New Zealand, these other oral agents, Betmega, Maravirogoran, and sometimes they're not enough. And so there are patients that I know that do both. So they become fully reliant on intermittent self-catheterization and Botox on a regular basis. So if somebody is doing intermittent self-catheterization and in between the times that they've got their planned catheterization that they're doing, that they're still getting urgency and they're still getting frequency in between those times, then it's definitely a conversation to have with the urology specialist to say, well, this is what I'm doing, this is what I'm feeling in between. Maybe do another bladder diary if you've seen a urologist or a continence team. I'm sure the people listening know what a bladder or bowel diary is. That's worth having that conversation and even ask and explain why it wouldn't be good or would be good in a personal scenario. Hollister have also bought, actually, myself and some MS nurses from around Australia and New Zealand put together with Hollister some wellness or living well with bladder and bowel guidebooks for continence, and one also for sexual wellbeing and intimacy that are through Hollister. And I know that MS Auckland also have a link for that or for those two booklets that you can access online. And there are hard copies available maybe if you speak to your MS team from MS on MS Auckland's website. So that can also be insightful because it talks about in general bladder wellness, bowel wellness, talks about UTIs, and then there's a separate booklet for intimacy, connection, and some sexual health stuff. And then it also has links to Continence Health Australia and some other New Zealand resources as well.
Perfect. So we still have a couple more questions to get through. Question, can estrogen help?
Yes. So absolutely, estrogen can help in women, obviously. Yes, that can be really helpful because with aging, things change. And so elasticity of the urethra can change and it can become dry. And that can, when the urethra ages, instead of nice smooth muscle, it comes like a little, not like a flower, but it has these little crevices in it, and so you increases your risk of UTIs and things. And so estrogen cream can be very useful for some people.
And the last question that we have submitted at the moment, and Nicola, I might invite you to come back on and finish us off after this, is that interested in your thoughts on PNE surgery for bowel issues or leakage.
Oh, someone's going to have to explain the PNE for me exactly, because my bowel stuff is okay, but not fabulous. I know I should know it because it sounds familiar, but I can't think what it is. Let me Google it.
Can expand on PNE surgery, because yes, it's not one I've come across in my reading.
Sorry, this is cheating, isn't it? Is that like peripheral nerve stimulation? Is this what the question is?
Yes, it's going to be better than mine. Yes, someone said yes.
Yes. So again, can be very helpful. I mean, at least now there's like sacral nerve stimulators that are implantable, and in the past that has been tricky because they weren't MRI safe. They weren't great for people, and with MS you need to have your MRIs, so that was an issue. And so a lot of people doing even for bladder and neurogenic bladder, doing some post-tibial sort of nerve stimulation, and some people find that helpful. I haven't had a lot of experience with that, but I have read about it, and in different areas some people find that very helpful. But with the bowel stuff, I would have to ask a gastroenterologist for more information about that, because I personally don't have experience with that, but I have heard about it.
Well, that is all of the questions that we have for now. So thank you everyone that has submitted questions and comments throughout. You've made it a really fantastic discussion. I will hand over to Nicola, but before I do, KJ, let me thank you for joining us tonight and engaging in such a wonderful discussion. It's been really informative and insightful, and I think helped a lot of people on a really important topic. So thank you, Nicola.
Well, thank you for having me. It's been lovely chatting to you.
Thank you so much. There's just been so much tonight to learn. I really liked how you said, if it's bothering you, you should seek help, right? Because that's just so validating, because we do all develop workarounds for things and sort of excuse them away. So, yeah, I hope that's given people confidence to reach out to their healthcare professional or mention it to their community advisor as well, who can help point them in the right direction. Yeah, there was a lot that I learned, even about soft drinks, having being an irritant to the bladder, which would just not occur to me. So thank you both so very, very much for giving your time and expertise tonight. And thank you everybody for tuning in.
Thanks everyone.